Well, good afternoon and welcome to this week's Independent Sage news briefing. I'm Lily and it's a pleasure to be chairing this briefing today. We are in an emergency. Coronavirus infections in the UK are rising. You will have heard this on the news. We may be lagging behind neighbours like France and Spain, but let's make no bones about it. This is a real crisis developing. The government has announced Operation Moonshot. This is an ambitious program that pledges to test 10 million people per day for COVID-19. The question is, will it work? Needless to say, we've got a heck of a lot to get through in the next hour. So first of all, thank you everyone for joining in. Thank you for those of you who've sent in your questions, which we will come to shortly. But we're first going to start with a presentation from Professor Christina Pargel, who will take us through the latest coronavirus figures. Christina, over to you.
Okay, thank you. So I'm going to be reasonably brief to allow plenty of time for questions, and I'm going to spend almost all of the time digging through the latest increases in terms of total cases, positivity rate, where they are, and so on, and then just summarize that and then pass over to Dina to really talk a bit more about testing and strategies for testing. Just going to start with hospital admissions. This is just England data for now. And there has been now an increase over the last week. It's still small numbers, but it is now going up after a long period of coming down and then a period of being flat. The number of new UK confirmed COVID cases. Well, last Friday, when I gave this presentation, and I said, we were on 1,700, and then I was like, I wonder if we're going to get used to 2,000 or 2,500. And then over the weekend, we saw this big increase. So certainly after the kind of slower increases we saw in July and August, it has accelerated. And if we look at positivity rate, we see that the acceleration is matched there. So this is not about people being tested. This is pillar 2 test done in the community in England. Since August, there's been pretty much no change in the number of people getting a test. And over the previous week, this is up to the 2nd of September, it went from almost 2% to 3% in a week. That's quite a big increase. And this is note that this data only goes up to 2nd of September, so it's before anyone went back to school. So last week of August, really. So we're seeing it there. This time I've also managed to find, thanks to Catherine Finnessy for helping me with the data this week, positivity rates for Wales and Scotland, and just showing them here. So you can see that the slow increase and then the more rapid increase more recently is mirrored in Wales and Scotland too. I haven't got the Northern Irish data yet. Scotland goes up to the 9th of September. It's slightly more recent data. And you can see the rate increasing there too last week. England has the highest positivity rates though, and then Wales and then Scotland. This is also now borne out by the King's College COVID Symptom Tracker app. They have 4 million users who report symptoms every day. They released a news report a couple of days ago saying that we are now seeing a significant increase in cases in the UK with over 3,000 daily new symptomatic cases. So that doesn't include people who don't have symptoms, and they estimate R being 1.2. And say they're confident this is a statistically significant increase and there is more transmission. ONS infection survey that was released an hour ago also says that the recent estimates suggest the number of infections has increased. And they say that the people testing positive is in the younger age range, 17 to 24 years and 25 to 34 years, and the number of people over 50 is stable or declining. Now, that is consistent with this really big research study called REACT that's run out of Imperial College London. And they have literally just released their latest data about 5 minutes ago. But I've had a very quick look, and that tests every 4 or 5 weeks. It tests 150,000 people across England, and they have also reported a real surge in infection since July. They said there was a small increase July to August, and they estimated R then at being 1.3, and then they've just finished a 2-week round of testing up to the 7th of September, and there they now estimate R as 1.7, and it has accelerated. But again, they say that almost the bulk of that infection is in younger people, and the lowest rate of infection is in people over 65, and that helps explain why hospitalizations and deaths have remained so low. And that is a good thing, but it's very concerning that this is now spreading among younger people. So where are the cases? This is a map of cases per 100,000 people over the last 7 days across the UK. And you can see now that the Northwest remains a big hotspot. There are a couple of hotspots in Northern Ireland and Scotland, but actually it is now the whole of the UK is seeing kind of a rise in cases. If you're looking at positivity rates by region, again, you can see the last week it's just kind of going up. And the only places at the moment where it isn't really going up is the Southwest, which has been pretty low COVID rates the whole time. And the this region here, which I can't remember which one that is now. So that kind of is also what Chris Whitty was saying in his press conference earlier this week, that this is now kind of across the UK, and it's no longer just in certain hotspots which are easier to manage. So that's kind of where we are. So what does that mean? Well, deaths are still very low, and hospital admissions are increasing, but they're still low. So that is a good thing. But there has been a steep increase recently in transmission. I think we can just say that now. All the evidence is pointing in the same direction. The increases started before schools went back, and we know that universities are coming back, and we know people are going back to work. So we are kind of in a situation where there is going to be more mixing in the context of higher transmission. And that is concerning, especially given the issues with testing right now, that we know that people with symptoms cannot get tested. Some people, not everybody, they're still testing lots of people. But the risk is that then those people aren't isolating and their contacts aren't being reached. So that's kind of the risk of what's happening right now. It would also really help in understanding this data if there was more transparency in reporting cases, you know, by who is getting tested and why they're getting tested. So distinguishing between kind of tests for screening, tests of people who don't have symptoms, and test people with symptoms would really help us to better understand the increase in. And Dina's going to be talking a bit more about testing in a minute. And we really urgently need to improve testing capacity and get it back up to where it should be, improve contact tracing, and really improve support for isolation. There was a paper coming out last week from data in May showing that of people with symptoms, only 25% were isolating. So that is really concerning if that's still the case now. But, you know, and I've been a bit gloomy, but there is good news, right? We're still a long way below where we were in mid-March. You know, the height of the pandemic, there were well over 100,000 new cases a day. We're not there, we're nowhere near there. It hasn't reached more vulnerable populations in terms of older population. And we do have the time to bend the curve back down. We're not at the R rate we were back then. And we know what to do, right? The government has to, you know, actually really improve contact tracing. And we know, you know, we can do social distancing, we can wear masks, we can do so that's where we are. So I'm now going to hand over to Dina to talk about testing.
Thank you, Christina. Can I just butt in over to Dina? A quick question for you. This is a bugbear of mine that I drive my wife mad with because you very helpfully reported the positivity rates, the percentage of those being tested who are tested. Why is this not the number? I'm sure you've covered this probably in previous briefings. Why is this not the number that is reported in the media, as opposed to the number of people testing positive per 100,000 of population, which obviously takes into no account of the number of people being tested?
Because in England, it's hard to get that number. So NHS Test and Trace publish it every week, but they're always a week behind. Local authorities publish it, but you have to go to every local authority website and you have to dig through it, and none of it is standardized. Scotland and Wales publish it every day. So, I mean, it's much easier. I mean, they do have better reporting than we do, and Northern Ireland too. But I mean, the reason people don't do it is because it's difficult.
It's difficult to find. Okay, thanks. Thank you very much, Christina. Okay, so we are going to move over to Professor Deenan Pillay, who's watched a presentation on test and trace. Over to you, Deenan.
Can you see my screen?
Yes.
Right. Hi, everyone. So with IndySage, we've been working on a sort of framework for testing that we've just issued today. This is more around what are the criteria that we should use for thinking about new testing strategies or even existing strategies. And the first slide I show is actually going back to basics, really, but is taking us away from this obsession that there's been around number of tests undertaken. We're all familiar with those daily press conferences from government where the number of tests per day were identified. In reality, that's a meaningless number because, of course, the key thing is the function of tests. And I just outline here three broad areas of functional areas that determine why we would want to be testing and why we are testing at the moment. And these are not mutually exclusive, but they are different in terms of they lead to different actions. And of course, a test is no good by itself. The number of tests is no good unless we do something about the results of those tests for those individuals who are tested. So first of all, we want tests to diagnose COVID disease in symptomatic individuals. And this is the mainstay of testing in the UK at the moment. This is the mainstay of the test and trace program. And the purpose here is for those individuals who need clinical management, need to go to hospital, need to be treated, then of course a positive test is important. But in addition, the purpose here is infection control of their contacts. In other words, that whole test and trace cascade whereby the initial test leads to requests of that person being tested, of their contacts and follow up. And I'll come on to that a little bit later. The second function of testing is how to manage infection in those close contacts of cases. So for instance, individuals who are asked to isolate because they've been in contact with a case, or for instance, those people coming back from countries of high incident infections asked to quarantine. The question here is, can testing be used to somehow modify or support that isolation or quarantine? This is not really being used at the moment in the UK, but of course there's a lot of discussion about this, and we need to be mindful. And the sort of tests we use for those sort of criteria may be very different to the tests we use in the first category. And then the last way in which we can use tests is to identify infection within communities. And what I mean by communities is groups of people, whether in a workplace, for instance, in hospitals, healthcare settings, social care settings, or universities, as is now being discussed. And we're aware as well that many private organizations have also, workplaces have started testing all their staff. Think of Premier League football clubs testing all their staff twice a week, and many private companies are doing that. And of course, that is not necessarily to identify individuals, but maybe around identifying the fact that there is staph infection transmitted, and that then leads to a public health response. And there's some interesting diagnostic approaches to this. For instance, in some situations, there's been a detection of virus in sewage as a way of, if one can look at the sewage specific, for instance, halls of residence for students has been used in the US, then that may be an early indication of needing to instigate public health measures. So this slide is important, and I think any discussion on testing we should be thinking about, and the question should be asked is, why specifically are we doing this testing, and what is the follow-up process needed to make sure that the testing is worthwhile? So now, how are we doing? Well, Christina has outlined, as she does each week, the sort of numbers and also the sort of test and trace figures. And clearly in the first category here for the test and trace, we're doing pretty poorly. And I think the most important figure that Christine mentioned was in those individuals asked to isolate. Even once we get to those, it is far less than 50% of those people from studies done so far less than 50% who are actually adhering to that isolation. And clearly, isolating yourself is a very difficult thing. It's financially challenging, socially challenging. And actually, with those sort of figures, it calls into question whether the test and trace program is functional at all at the moment without thinking about those things. So let me just go to the second slide about how then, what has happened over the last week. Well, of course, there's been a lot of discussion this week about the performance of our testing and what new strategies. And interestingly, on the 8th of September, not the most radical blog site, Conservative Home, stated, with NHS test and trace repeatedly failing to meet targets, confident in government's tracing strategy is faltering. That's government's own blog site or Conservative members, and saying something pretty critical of the government. So how did government respond to that? Well, Matt Hancock the next day, this is the Daily Telegraph, blaming us, the people, for the failure, saying that we're all testing when we're not meant to be testing. We should only be testing if we're symptomatic, but in fact, too many asymptomatic individuals are testing, and that's taking the testing away from those that need it. But almost immediately, of course, we get Boris Johnson and the leaked documents saying that he's actually hoping that we test everybody and throwing £100 billion at this. So clearly, in the space of one day, 24 hours, that have so many mixed messages coming out of government circles, and all these three reports are from government or those close to government. It's no surprise that in fact we need far more clarity, and in fact we need to get trust within our population. So what are we suggesting as a framework for COVID testing go forward? First of all, whatever testing is undertaken is to establish at the outset the primary function of that testing and the pathway following the testing that will ensure is taken appropriate action. And we've already talked about the limitations of that. Secondly, we recognize that with an effective find cases, test, trace, isolate and support those in isolation. This is the process and procedures that we've been pushing for some time within IndySage. With a functioning service like that, then we should we have the potential to limit and reduce and actually move towards zero COVID by the end of the year. But a large amount of money needs to be, an organization needs to be put into that. Thirdly, we need to have in place mechanism to assess the effectiveness of each of our testing strategies. It's impossible otherwise to monitor how we're using resource, what is going wrong. And an example here is that we still do not get any figures from Test and Trace on the proportion of those asked to isolate who actually isolate, which of course is the whole point of that process. We need to assimilate testing pathways into existing structures. And as we've seen from Lighthouse centers and so forth, the development of completely parallel new structures to all of our existing PHE, NHS, and public health functions that have been running for some time, developing something separate to that just leads to problems, particularly in terms of data management and procurement and organization. We need to provide very clear messaging and engagement. So anything that talks of larger number of individuals being tested actually requires the buy-in of large proportion of the population. I think we've already seen over the last week the tensions are starting to develop between, for instance, wearing masks and not wearing masks, and we're in a vulnerable situation as a country, and therefore testing can help to get us out of this, but it's got to be done with the support of those individuals. And finally, to ensure that there is public trust in the new technologies that, of course, continually being touted as the answer to our problems. And I'll just finish with a quote from our document that is issued today. We must row back from portraying in any initiative as world-beating, moonshot, a magic bullet and the like, regardless of the success or not of current vaccine trials. In the end, testing will need to be one component of a series of measures, including behavior change, social distancing, and public health contact tracing in moving us towards zero COVID. Thanks.
Thanks very much, Deenan. Okay, so we're now going to go straight to questions from the press and the public. Can we start with a question from a member of the public, David Smith?
Hello there, can you hear me?
We can, yes.
Brilliant. I guess my question is, what does a realistic moonshot look like? How would it work, and what are the necessary conditions needed to get such an approach up and running? And alongside that, is that the sort of thinking that should be advanced anyway, with a vaccine waiting somewhere in the wings?
Okay, thank you, David. Who would like to address that? I know, Anthony, yes, please.
Well, I'm only coming in because I have to leave in a few minutes.
You want us to hear your voice?
Yeah.
Thank you.
No, I'm sure actually Deenan and Christina presented very clearly why a moonshot. My fear, and I'll be very frank, this is a personal view, I think it's a distraction. I think we've had the app that was going to solve problems, the immune passports. I think this is something of a PR stunt to, you know, the Boston Consulting Group or whoever is advising government came up with this. And it sounds great, and it kicks everything down to March or whenever it's going to come online. And, you know, even the government statistical advisor, Sir David Spiegelhalter, showed a couple of days ago how absurd it was, because he said if your test is even 1% wrong, you would have 100,000 people a day being told to isolate who were not actually positive. They would be false positive. So the whole thing is why we're talking about that. Sure, let's explore salivary tests. Let's explore better ways of doing testing in the workplace. But let's follow what Deenan has just laid out and follow a very careful approach to setting up again a proper working find, test, trace, isolate program that is integrated into the National Health Service. My big fear about this is that the £100 billion being talked about, which is nearly 3/4 of the NHS budget, would be a massive, not only a distraction, but a threat to the whole of the NHS that we've come to cherish over the past 70 years. So I'm very worried about the politics of that. I'll stop there.
Thank you very much, Anthony. Yes, Christina.
Just to say, on not talking about the feasibility of how Moonshot might work, but anything that isn't planned to work until next spring is too late, right? And we know what works. We can see from other countries that a really effective contact tracing works. We know how it's done. You could do it for a fraction of 100 billion. You could do it for less than $1 billion. So if they want to spend money, why not spend it on actually supporting people to isolate? I mean, I just can't understand why they, I mean, it doesn't make any sense to me.
Lots of nods. Yeah, and anyone else to come in on that?
Just
Alison, yes.
Yeah, just to say, I completely agree. This is very expensive, and not least because many of the proposed tests haven't been properly validated and are not even been evaluated in screening programs such as the ones they're proposing. So we really need to get the basics right, as Christina says, and Anthony. Let's get the symptomatic people, find, trace and isolate, use money to support people to isolate. If only 20% are isolating, that's really very serious. And secondly, we're going to have plan. Let's consult the UK National Screening Committee, make sure there's proper evaluations and proper implementation. The screening committee has got decades of experience in dealing with mass testing and mass screening programs. The government's got rights and Boston Consulting, when they have the very experts they need within the NHS who are designing research programs and implementing mass testing programs on a daily basis.
Thank you, Alison. We lost your video, but we heard your answer very clearly, so that's fine. Okay, I think we should move on, and we go now to a question from a journalist, Alexandra Thompson from Yahoo. Alexandra.
Hello, sorry about that. Hi, everyone. I'm going to go slightly off topic here. I want to talk about Christmas. I think it's a beacon of hope for lots of people before we write off this awful year. We saw on the headlines, people saying the 6 people rule in England may last till March. How do you see Christmas looking under the current government strategy? What would you like done to improve the potential of celebrating this year? And also, realistically, do you think people will adhere to this? Because I think they're fed up and Christmas is a highlight for people. Sorry, lots there.
Thank you, Alexandra. Yes, I agree. I mean, we hear talk of it potentially, the rule of 6 carrying on well into next year. And I think you're right. I think expect people to adhere to it, particularly around Christmas time, is going to be very, very difficult to maintain and to check. Does anyone... Zubeda, you look like you're about to raise your hand.
Thank you, Jim. I think it's absolutely right that we should have some hope, but I think it's important for us to have realistic hope. Now, that's part of the problem with Operation Moonshot. We know that we've now heard that it's not feasible, it's not practical, there's issues around transparency, there's issues around its science and numbers. It is not fair for the government to raise false hopes in that way, even if they're looking at March. Now, actually, having said that, you're absolutely right to say we should have a goal. And Christmas isn't a wholly unrealistic goal. We could have some semblance of a Christmas if we had the find, test, tracing and isolate system that Independent Sage have been talking about. Now, it's absolutely right to ask questions, to raise questions about the nature of the tests, where you get the tests, how you do the tests. We know that there are huge issues around the current test and trace system, but there is absolutely no point in having a test and trace system unless people can afford to self-isolate, unless people are supported to self-isolate. We know at the moment something less than 20% of people are self-isolating, and those are the issues that the government should be focusing on. And I think if they got that right, if they spent, as Christina has said, even £1 billion on the FTTIS system, the test and trace system that we have, working with local public health, then we could have a pretty decent Christmas.
Thanks, Zubeda. I know a few of you got your hands raised. Carl, can I just first come to you and ask you, I'm sure you'll have something to say about this, Alexandra.
Yes, plenty to say. And also, I think this touches upon a key theme here, which is the timing of strategy and the time sensitivity of all of these policies that include the social distancing, the rule of 6, and also investing resources in Moonshot programs relative to contact tracing, FTTIS. So the quantitative modeling suggests that what we are seeing now is the inception of a secondary wave. And by secondary, I mean the virus is now starting to get into those parts of the country that hitherto it has not reached, or at least communities, as distinct from some loss of immunity and a second wave proper. So that means that the timing issue becomes absolutely crucial in relation to whether you look at forward to a Moonshot approach that will be realized in, say, 6 months, as opposed to focusing now on what is self-evidently a very delicate situation. So just bringing together the two big themes, which is what is the purpose of testing and the increasing anxiety about the increasing prevalence of infections, what that means from an epidemiological modeling point of view is that we have carefully constructed a knife edge, and a knife edge which is very anxiety provoking because no one knows what is going to happen next. On the other hand, that knife edge that has been gifted by the social distancing that we've all invested in, and I should also add the accumulation of protective immunity, the things that we have been through, have places on a knife edge which actually has a very positive and important implication. Mathematically, it's structurally unstable, which means it's very sensitive to any perturbations or changes in the parameters. Now, the one key parameter here that we have control over is contact tracing. And it will work now. It won't work after the second wave or the secondary wave has ensued. It wouldn't have worked a few months ago, but it will work now if we invest in resources into it. Another point, I think, in terms of should we be optimistic about Christmas and really reinforcing this notion of the time sensitivity and the urgency of investing money now in things that we know that work, specifically a public health response based upon contact tracing and support. We don't need to have a contact tracing system that is working at 100%, because we've got this knife edge, very sensitive, very unstable situation, just nudging the efficacy of the contact tracing towards a more effective performance will have a material effect in attenuating the secondary wave. And looking at our models, it would look as if by Christmas we'll actually be on the tail end of the secondary wave. So if we can augment and direct resources now to contact tracing, then I would imagine that we may have a more optimistic or more usual Christmas than otherwise.
Thanks, Carl. I'm guessing you didn't mispronounce Moonshot back then. But Susan and Stephen, you both have your hands raised. Susan, come to you first.
Thank you. Well, I wanted to build on what Carl said in terms of the if. It is in our hands, but how do we achieve that? And it requires a couple of U-turns from the government, because for us just to continue saying that we need a functioning test, trace and isolate system in order to get out of this doesn't seem to have had any impact. And what is needed is the government to accept, especially given the very obvious current debacle about total lack of tests for most people, is that the contracts need to be given to those people who have the expertise and those people who are trusted by local communities. And that means not the huge, big private corporations that appoint lots of subcontractors to run call centres. It means providing the money and the resources to the local public health infrastructure and primary healthcare structure who can deliver this. So that's the first U-turn that is required. And the government's had quite a lot of practice at U-turns, and this one would be massively welcomed. The second U-turn that is absolutely required is one that will rebuild people's trust, because there's no point having this system if only 20–25% of people, for example, are giving contacts because they don't trust the system. That's why they're not giving the contacts. So to build that trust, the government needs a U-turn to accept the advice that its Scientific Advisory Group Emergencies, in the form of its Behavioural Science Advisory Committee, has been giving for months, which is to consult with communities, whether that's local communities, young people, Black and ethnic minority groups, listen to them, learn from them, and go forward in partnership with strategies where adherence will then increase and we'll get better solutions. So 2 U-turns, and it will pay itself back hundreds of billions of pounds, and we'll be able to get out of this quicker. So we can get out of this by Christmas. We can spend Christmas with loved ones, but only on the basis that the government does things very differently.
Thank you very much, Susan. We do need to move on. Stephen, if you wanted to make a very quick point on this, because I now see we have a whole host of questions we need to get through in the next 24 minutes or so.
Well, I was going to start off by saying that I hope we do better for Christmas than we did for Eid, where in effect we cancelled Eid the night before. In terms of can we get things better by Christmas, I think everybody's saying yes if we have the right policies. And the two areas where we can act are, number one, we need to limit exposure to the infection so that people don't get infected in the first place. And we need to have the test and trace system up so if people get infected, it doesn't spread. Now, lots of people have talked about the testing system. And if there's one thing we're all saying, and it's very simple, it's this: use a tiny fraction of the 100 billion to pay people to self-isolate. It will be far more effective. But I just want to make a couple of comments about the issue on exposure, because one of the problems is that the government is doing contradictory things. At the same time, it's trying to limit exposure by telling us only 6 people can meet. It's increasing exposure by trying to force people back to work even when they can work at home, which means they're more exposed both on public transport and in the workplace. And it's encouraging people to go out to pubs. Boris Johnson said it was their patriotic duty. So the other U-turn we need is, instead of a series of ad hoc measures, some of which are contradictory, we need a comprehensive policy to limit unnecessary exposure. We need to make sure that people can work at home if necessary. We need to make sure that workplaces are safe. We need to make sure that people aren't exposed. And that means the government has got to take responsibility for its own policies and not just blame the public. Because if you blame the public, you're not going to get adherence, you're going to get resistance. We've all got to play our responsibilities.
Thank you very much, Stephen. Okay, so we move on to a question from Richard Bergen MP, Labour MP for Leeds East. Richard.
Thank you very much. I think that we all desperately want to see an increase in testing. And I think this has become really ever more important after the chaos and the shortages that we've seen this week. But something that I'm concerned about is what I've heard about Operation Moonshot, because what I fear, at least, is that this risks becoming really another white elephant that distracts us from the real job at hand. So I'd like to hear more really about the views of Independent Sage on this, please.
Who would like to address that? Dinan, yes.
Yeah, thanks, Richard, for that question. I mean, we do feel very much that this is a distraction. It's a good word. It's a distraction which clearly is driven by the current political environment. Unfortunately, but key is a little bit what Susan has said previously. It, by just announcing it as an aspiration with no details of the purpose, no details of how it would happen, other than which consultancy companies would be involved, which of course is all over the documents that I've seen. It has a dangerous impact of undermining, our public health and our NHS at the moment, and actually taking us further away from our ability to respond in the way that we're talking about. So I would say, there's a personal view that we need to almost like aim to go back to basics and push very hard for even the lighthouse labs, as they now stand, to be repatriated back to NHS, Public Health England structures and so forth, in order to bring the confidence back for achieving what we want to do. And I think it's very clear from the modeling that Carl and others have done, is that if we really improve sufficiently in that whole test and trace program, we can actually minimize the infection by Christmas.
Thank you very much, Dian. Okay, the next question is from journalist Chloe Chaplin from The Eye.
Hiya. So I wanted to ask about the perceived shortage of tests, or people struggling to get the tests. The Department for Health weren't able to provide any proof or verification to me as to where the estimated 25% increase of people who are asymptomatic getting tested. I also don't know how they'd be able to verify that anyway. And from what I saw from Christina's slides at the start, there wasn't a huge increase of people applying for tests for the last 2 weeks of August. So do you have any insight as to why there seems to be a problem with some people getting hold of a COVID test?
Who would address that? Christina, yes, I was going to go and ask for Sir David's advice on who he should point the finger to, but you've jumped in. Thank you.
So in terms of the slide I showed showing the numbers, that's the number of people getting a test. So that hasn't really gone up. I have no information on how many people are asking for a test. I have no idea where Matt Hancock got his 25% asymptomatics from either. In hotspots, they have been testing some people who don't have symptoms, but that's kind of, as far as I know, they've been asking people to get tested. And then outside of those, you have to go via some kind of screening tool which checks for your symptoms. So I have no idea how they know whether people have symptoms or not. But even if they did, that would only reduce the positivity rate. Because if you don't have symptoms, you're less likely to have COVID. So it doesn't explain the latest increases.
Thank you. Zubaida.
I think it's quite important that we call out some of this victim blaming that's been happening by Matt Hancock and Boris Johnson. I mean, the reality is people don't know if they're symptomatic or not. You know, all they've done is listen to public advice about what are the symptoms, and they go on the basis of symptoms. It's extraordinary. It's an extraordinary accusation to make of people that, you know, they're not ill at all and yet they're going for tests. I mean, if that was the case, then we would have seen that throughout the pandemic. I think what we need to pay more attention to is the fact that people, whether symptomatic or asymptomatic, are having to travel between 75 to 100 miles out of their area when they're, you know, symptomatic. So when they think they have coronavirus, they have to leave their area, go 75 miles to 100 miles to a car park to untrained people, giving them a swab test. And as Anthony rightly pointed out before he left, that should be local. That should be close to your home. As Susan has pointed out, it needs to be with trusted GPs and so on. And that's the thing. We need to go back to the basics. Absolutely, as Deanan says, that's the most important thing. And we need to call out this victim blaming. It is not appropriate and it doesn't raise public confidence.
Thank you. Stephen, is it really brief? I've just realized we have 12 questions to get through in the next 15 minutes or so, which is, so I'll let you come in on this one briefly.
Okay, I'll be extremely brief. The government seem more intent on managing blame than managing the pandemic. To tell people off for getting tests is profoundly dangerous, because the real problem is this, that when people are unsure, if you tell them, oh, you mustn't get a test if you're not unwell, they will delay. It will be longer before people get tests. They will be infectious for longer without doing anything about it, and the infection will spread more. So what Matt Hancock said is not only wrong, it's profoundly dangerous, and it will increase the pandemic.
Thank you. Okay, we now go to another question from a member of the public, and I see you've joined us, Mary Charlton. Over to you.
Hello. Rather than backing the expensive and unlikely goal of regular testing for all, would you support incentivising people to report their state of health every day on a symptom tracker app, such as the one from King's College London? I realise it wouldn't pick up pre-symptomatic or asymptomatic cases, but it could be used to nudge people into getting tested for COVID, perhaps especially those with more minor or atypical symptoms.
Who would like to address? Carl, I think we should come to you.
Thank you. That's a great question. So in using that question as a vehicle, just to sort of come back to Deanan's deconstruction of why we are testing and why we are trying to solicit data handles on the epidemic, that suggestion, which is a great suggestion, and in a sense it's something that King's College Hospital have been pursuing as a way of keeping an eye on prevalence of infection both nationally and regionally. That aim speaks to the third reasons for doing any kind of testing or soliciting data. It's equipping people in a position to inform local authorities and public health teams that your prevalence of infection in your area is rising, and that would be the purpose of the screening use of testing. And as such, I think that would be a very useful thing. And then what you would have is that you could contextualize and alert the local public health teams to do shoe leather or good old-fashioned public health, and then get into the find, test, trace, isolate, and support the end-to-end process that will actually make a difference. So that is a very good thing. It also allows us to just revisit why on earth you would need a large-scale screening program if you had that kind of way of assessing the prevalence of infection. Of course, you don't need masses of tests. You just need 10,000 a day over 10 days, and that'll give you a very precise handle on the prevalence of infection. And in part, I'm also answering Jim's question here, is why haven't we been using the positivity data? One subtle answer to that actually speaks to this issue of surveying symptoms with unbiased sampling via reporting apps, but versus going out there and doing PCR testing. If you, like Matt Hancock has suggested, start fiddling with the propensity of people who are symptomatic and therefore infected to selectively go forward for testing, you introduced biased sampling. So imagine the situation where the only people that can get PCR tests in the next week are those that are symptomatic, and let's assume they're all infected. You would then have 100% positivity. So you're completely invalidating the utility of that kind of screening. So again, the whole Moonshot proposal sort of fails, even on the most, if you like, obvious criteria of Deenan's tests, and could easily be replaced with a screening program using our current capacity, complemented and supplemented by the kinds of reporting app that Mary has just suggested.
Thank you, Carl. We next come to a question from journalist Tom Magner, Carers World Live.
Thank you very much indeed, Jim. Unpaid family carers in our audience tell us they'd like public messages that are simple, clear, and apply to all, whatever their age and situation. So how can the public trust if it appears to them that the science is not robust or reliable enough, because it allows politicians the wiggle room to make what are quite a lot of, at times, confusing exceptions to the rules?
Susan.
Well, science has always got a degree of uncertainty around it. So the issue is, how do you communicate, on the one hand, uncertainty of what we know, and also the fact that this is a new virus and new science and new understanding is emerging all the time. So you want to be able to communicate that on the one hand, but on the other hand, be very clear about what that means for the population at a given point in time. And that can be done, but it does require very clear, very concise, and very consistent messaging. And that means consistent from different individuals, along with written messages, and along with what people do, as well as what people say. So it is possible, but it does require following the scientific advice that's given from the behavioural scientists on the Scientific Advisory Group of Emergencies, advising the government, and that hasn't really been taken up as yet.
Schoolboy error, I was muted. Sorry, David, over to you.
Yeah, Jim, I just wanted to come in with a counter example of a government where the behaviour has been considerably better and is very much trusted by its government, and that is in Greece, where Sotiris Tsiodras has now been described by the New York Times as a COVID-19 hero. And he is certainly regarded in Greece as the big hero of the year. Now, what happened was the Prime Minister of Greece back on 4th of March went on television together with Sotiris and explained Sotiris was the expert in Greece. He was working with other experts in Greece and elsewhere, and he was handing the control of the epidemic over to Sotiris. Sotiris then appeared on television at 6 o'clock every evening, speaking to the Greek people about what progress was being made. But he also set out then, early in March, the full strategy right the way through to going into lockdown, to coming out of lockdown. He even put a timeline on it. He also put in caveats about what might happen if not. That was followed almost precisely. But what is really important to understand is that the Greek people are so proud of themselves, but this person is calm, he has the knowledge, he has a deep respect for all victims of the crisis and a dedication to the nursing staff. It all comes over in the way he speaks to the Greek people. Now, the net result is the total number of deaths in Greece is less than 200 for the whole epidemic. And they emerged from it before any other European country. So I think we can contrast that with a government that is pushing the scientists to one side and saying, we understand better than the scientists. And really, that is a very dangerous situation. I think Tom's question really is a very important one.
Thank you, David. Okay, now a question back from a member of the public, Levi Pay, sorry.
Hello there. This week, Exeter University announced that it was buying in testing, private COVID testing for its own students and staff from a company called Halo. And part of the reason for this being to avoid overburdening the NHS. Examples like this, for me, raise a lot of important questions about the best way for us to make use in a coordinated way of private testing capacity. And so I guess as a starting point to thinking that through, do we have data to help us understand the approximate scale of the private COVID testing capacity that we have in the UK?
Does anyone have any? Dinan, yes.
Yes, thanks, Levy, for that question. It is an emerging theme, actually. I know certainly, because I've been involved in some of the discussions, that the Premier League, for instance, in the UK is utilising, the Premier League has a contract with private companies to provide all that testing and advice, and different companies around the UK are doing this. And there are models around elsewhere for those sort of those broad approaches. I certainly I'm familiar with a number of universities in the US that, for instance, are doing the same sort of thing. Having said that, I think the whole discussion today has been about, you know, what are the criteria for effective testing, and it's all too easy to fall into the trap, in a way, like the Moonshot project is just to test everybody on the basis that some miraculously will actually solve the pandemic. And of course, it's what you do with that that's important. So how you deal with contacts, how you deal with serious cases who need hospitalization, so on. And all I would stress, given that the reality is that Exeter, as well as other organizations, are going full steam ahead, is that it's essential that this is done in partnership with local public health, local primary care, university health authorities, health systems, and so forth, and in order that there can be some rationality to this, and it can actually fulfill the purpose that it's there for.
Thank you. Next question is from Amanda Ferguson, freelance journalist. Amanda.
Hello, everybody. Thank you for this facility. It's great. I think my question was a bit about the psychology of all of this, of where we find ourselves now. And what I can see is like an increase in skepticism among some people. It can actually be quite exhausting whenever you're having to try and explain it to people. But I think it's on a spectrum from those on the extreme who think that COVID is like a scam and state control and so on. And I'm not sure there's much we can do about them, to those who actually have legitimate concerns, who are challenging what they're being told or asked to do because it doesn't make sense to them. They're asking questions, why is COVID so important when, cancer services and other services are being impacted and deaths will result from that. And I'm just wondering how much is it to do with poor communications, when announcements are made but not fully explained, not clarified. So how do we turn that around, and which countries are getting it right? I know Greece was mentioned there, but are there any others?
Steve Riker, is this a question for you, I think? Oh, you're still muted.
Unmuted now. Yeah, I mean, it's an extremely important question. The good news is that can you hear me now? Sorry about that.
Yes, yeah,
Good.
you muted
Okay.
again.
Good. The good news is that on the same day that the so-called Rule of Six was announced, polling from YouGov showed very strong support for restrictions. People know there's an emergency and know that something's got to be done. So overall, 80% of people were in favour, and even amongst the 16 to 24-year-olds, where we hear that they all want to go out and party, 70% of people supported it. So clearly, people understand the need for restriction. People are not stupid. The bad news is we are seeing increasing division between those who want restrictions and those who don't. And a report that came out from Demos today in The Guardian showed that actually in many ways that divide is more acute and more conflictual than the divide between Brexit and Remainers. And I think one of the reasons for that goes back to the issue of blame culture. If you begin to say that those who get infected are doing something wrong, it's their fault, you begin to moralize things and you begin to say they're bad people and they're to blame. If, on the other hand, you recognize that often people are infected not because they want to do the wrong thing, but they don't have the necessary support to do the right thing, and that in many ways they are victims of being in circumstances where they have to go out, they have to go to work, you don't get that type of moralization. And instead of blaming people, you ask, how can we support people to do the right thing? So I think it's absolutely essential that we pivot from a blame culture, which implies that you've done something wrong and deserve condemnation if you get infected, to a support culture, which asks, how can we support people to do the right thing? And what's more, if you blame people, you're going to alienate them and they're not going to listen to you. The best way of getting adherence to authority is for people to see that authority is on their side and supporting them. So one of the fundamental resets we've got to get is away from blaming people, away from this divisiveness and polarization, which may lead to tension and conflict, and towards a culture of support and policies of support and respect for the public as well.
Thank you, Steve. Zubaida, did you want to come in briefly?
Yes, very, very briefly. There's also an assumption that the public are scientists, that public are scientists, that head teachers are scientists, that every business reason Independent Sage was set up was because the science was not transparent from this government. And I think that needs to be made very clear, that if the science was transparent, if the public health informations were clear and consistent with their messaging, then we wouldn't be in this mess. So I think that's one of the most important things. The other thing is, if this government had a clear and transparent strategy, if we knew what its strategy was, and we're the scientists, we don't know what its strategy is. So how can you expect the public to know? So that's the other important thing that needs to happen, Amanda, is a clear strategy from this government about how they're going to get rid of coronavirus.
Thanks, Zubaida. We're running short of time, but I'm going to try and squeeze in a couple of final questions. The next one is from Grace McCaskill, who's journalist at the Sunday Mirror, sorry.
I wish. Hello, how are you doing? Just wanted to ask if the government, I mean, we're obviously putting a lot of emphasis on track and trace. I think given the current situation with the government, it's very unlikely that we're going to get there, given, we are on this knife's edge, we need to move quickly. If the government can't get its act together on track and trace, how do you experts see winter panning out? Can we go back to expecting the kind of 20,000 deaths, or Do we have some immunity now that might help us, or or are we really looking at the doomsday scenario, I think is what I'm asking.
Susan, and then Christina.
Well, there are some things that we can't do anything about, and some things that we can, as a population, do something about. During this session, we've been putting quite a lot of emphasis on the responsibility of the government to have some U-turns to change its policy and strategy, because that makes a huge difference to the population. But I think we're also going to have to look for leadership coming from other quarters. And I think leadership coming from communities, we've already had it in some situations where celebrities have come forward, for example, for school dinners for children, etc. And look at leadership coming from other sections of the population. And the things we can all do are the things that will break that transmission in the virus, which is not getting it into your eyes, nose and mouth because you're standing too close to somebody, or you haven't been washing your hands and then been touching your eyes, nose and mouth. Not wearing face masks is another problem. And ensuring that you reduce as much as possible the number of different people you're in contact with, the amount of time you spend with them, and how near you are to them, and whether you're indoors or outdoors. And I will repeat,
it's in our hand. It's literally in our hands then, really.
Yes. But another thing I will repeat, and there's a couple of things that don't make a lot of sense about the rule of 6. It's good that restrictions have been brought in. I do not understand why in England they say it can be from 6 households, given they want to reduce transmission between households. And the other thing, to have the same number outdoors as well as indoors. There's a global database that suggests of the transmissions to at least 5 other people, 97% of those have taken place indoors and only 3% outdoors. So,
can you repeat those figures again? There was how many indoors?
97%, these super spreaders, to at least 5 other people indoors and 3% outdoors. So really, I think one of the messages should be that we should be doing as much socializing as possible outdoors.
Okay, that makes sense.
While the weather holds out.
Yes. No, even when the weather doesn't hold out, put on more jumpers and cardies and hats and scarves and go for brisk walks.
Yeah. Buy a fire pit.
Christiane, did you want to jump
in?
David?
I was going to say something that's similar to what Susan said, is that we do have some control ourselves. But also, even if it continues to spread, we are still in a better position. We actually are much better at treating it in hospital. So hospital mortality rates have now gone down to about 10%. They were at 30% in March. We know that, for instance, some of those steroid treatments work. We are, I hope, protecting care homes a lot better than we did. So that was, a third of our deaths were in care homes. Hopefully that won't happen. If it does happen, then that is another national scandal. That would be unforgivable. I think a lot of more vulnerable populations now know who they are and they know to shield. So there are things that will, I think, stop us getting to that kind of level. But, we still don't know the long-term impact of having COVID for anyone. So we know that there are kind of people with long COVID and stuff. So we do want to drive down anyone getting it, but I don't think we'll be where we were. And then there are also models like Carl's that actually suggest that even with nothing else, we're not going to be where we were in March.
Yeah, I'm going to speak to him after, so thank you.
David, did you want to come in?
Yes, just very quickly, I wanted to say the level of infectivity in the country at large is a critical part of the answer to this question. Your question, Grace, is if the test and trace is going to continue to be inadequate, if the government is providing, then what is the way forward? Well, the epidemic is now increasing again, and it's increasing at a worrying rate. Not as fast as it was in the first case, but for all the reasons that Christina's giving, it's not as challenging as first time round. But nevertheless, it's worth remembering, South Korea and Hong Kong never went into lockdown, and they managed their entire situation extremely well by simply having a test and trace capacity that could meet the sick people that were emerging. So if we once again get the number of people, the infectivity level in the country high, it's going to be very, very difficult to manage it, even if we have a good test and trace system that's up and running. So I'm afraid partial lockdowns is the obvious way forward. It's not as if we can avoid that. We know exactly what Susan was saying about out of doors, relatively safe. Stay 2 meters apart, please, but it's relatively safe. But I think the question is going to be, how do we continue our economy, etc., in a second wave situation? The sooner we get it under control, the better. And Independent Sage has been saying all along, the summer was the time to get it under control, because the winter is when we all go indoors. So I think we're in a very difficult place right now.
Thank you, David. Okay, we've time for one last question. Member of Public Felix Krish.
Hi.
Hi.
Very quick question. My wife and I have been isolating pretty much since the 16th of March, as my wife's at risk. Given the confused mess of track and trace, can Independent Sage recommend any combination of testing or isolating that might allow us to have our children of 30 and 32 in the house at Christmas time? Sorry if it sounds a bit selfish, but it touches on everything you're talking about.
Thank you, Felix. I'll just get Christina to give an answer to this one.
So this is what I'm doing with my family, and maybe other people have different opinions, and Dina will probably be the best person. But so my parents are both in the shielding category, and I've kind of talked to my sister and her family, and we're going to try and isolate for 2 weeks before Christmas as much as we can. And then hopefully it will be safe to see each other at Christmas and not seeing other people, not seeing friends, not seeing my husband's family. You know, I mean, that's the kind of thing that we're thinking about doing. But obviously it has to be legal to do it. I'm not gonna, but that's one thing of trying to isolate yourself and effectively you're doing 2 weeks quarantine.
Yes, but if one of the parents is at risk with a particular condition, it's still something of a lottery, is it not, as to how safe it is to actually be able to do that indoors?
If you've been quarantining for 2 weeks
That's
and
safe
you
enough?
haven't got symptoms, then in theory you don't have it.
Right. Okay.
Thank you very much. Okay, well, that is all we have time for. So I'll just go over to Sir David King for some final thoughts.
Well, I'm in a difficulty in giving final thoughts, Jim. I wasn't here at the beginning and I didn't hear Christina's presentation. But I just hope that everyone understands Independent Sage is going to continue to be in the public domain with all of its thinking and its operations. And we consider these meetings to be a crucial part of our ability to deliver that.
Thank you very much, David. Well, thank you everyone for joining us. Thank you for all your questions. Apologies to those I know that we didn't get round to answering. Do please join us again next week. I'm sure there's going to be so much more to discuss. Thank you all.
Thank you.
Thank you.
Bye-bye.
Bye-bye.